next section that we're going to talk about is neuromuscular disorders and the sports injury. Now, if supposedly somebody's hand comes beneath a car crushed and he wants to know whether this limb will survive or not, for that we have mangled extremity severity score, also called as a MES score, which includes 4 parameters: shock, that is the blood pressure of the patient; ischemia, about the circulation distally; velocity of trauma, because an injury through a helicopter will not be same as through a bike. So velocity of trauma and age of the patient. Each parameter here is given a value. We don't have to remember that. Total score is up to 11. Score more than equal to 7 is an indication that this limb cannot survive, requires amputation. Overall in the world, the most common cause of amputation is a peripheral vascular disease. In India, it's traumatic. Some amputations that we should know of: Chopard's. Remember the mnemonic CIT sits. Chopard's is an area for intertarsal amputation. Lisfranc's, tarso-metatarsal amputation. They are anatomical terms. But what they are loving nowadays, Syme's amputation. It's an amputation to the ankle that goes 0.6 centimeter above the top of the talus. So this is Syme's amputation. If there's an amputation, you cut the skin, the muscle, the bone, the nerves. The cut nerves, they develop a swelling. They're called as amputation neuroma. Amputation neuroma is a very, very painful situation. Overall, the treatment of an amputation neuroma is surgical. You excise it. But if surgical option is not there, what will you do? You can go for TENS, transcutaneous electrical nerve stimulation, more than IFT, more than ultrasonic therapy. These are different modalities to relieve the pain, non-operative modalities. Remember, how does TENS work? It inhibits the pain gate pathway. If somebody's lower limb has been amputated, the leg, you have to give an artificial prosthesis to the patient. There are foot which are for Western lifestyle. They look artificial. They are called as solid ankle cushion heel. So the ankle is fused, do not have movements there. Neither do they have movement at subtalar joint. So solid ankle cushion heel foot. As compared to it, the Indianized version, which looks natural, is a Jaipur foot, which was made by a famous scientist, Dr. Sethi. Jaipur foot looks normal. It allows you to walk barefoot. It allows you with a small keel to have good ankle movements so that patient can sit on the ground. It allows you to walk on irregular surface because inversion, eversion at subtalar joint is possible and it's cheaper. Whereas Sach foot does not allow you to squat and is costlier. If there is an amputated limb and a patient rushes to you and says, "Doctor, can you put the limb back?" This is called as reimplantation. The order in which you carry out the repair is remembered by the mnemonic B-FAN-VS. You first repair the bone because that forms the base, followed by extensor tendon, flexor tendon, arteries, nerves, veins, and at the end you provide a proper skin coverage. This is called as B-FAN-VS. So bone, extensor tendon, flexor tendon, artery, nerves, vein, last is the skin. This is according to the Green's textbook of hand, which is considered to be the Bible in orthopedics. specifically for hand repair. When I look at the knee joint, if this is my femur and if this is my tibia, this is my fibula, this is the lateral collateral ligament, this is the medial collateral ligament, this is the patella, and here is the ligamentum patella going on the tibial tuberosity. If I enter inside the knee, just lateral to the ligamentum patellae lateral margin, this is the anterolateral approach. The most common approach through which you can go and see the knee inside. Arthro means joint, scope means to a tunnel vision, keyhole vision. Most common approach, anterolateral, most common. Or you can go medial to it, anteromedial approach, which is important for instrumentation when you're operating that area. Or you can have a superolateral approach, another approach through which you can have a look at the patellofemoral joint. Or you can have a posteromedial approach, difficult to do but described. Or you can have the Gilchrist approach going through the ligamentum patellae right in the center. So total there are 5 approach. Most common, anterolateral, instrumentation, anteromedial, patellofemoral joint, superolateral approach. 5 approaches. Knee joint. Knee is a structure which has got a strong quadriceps muscle in the top with the patella into the quadriceps, then the ligamentum patellae going on the tibial tuberosity. The femur articulates mainly with the tibia, but then there is fibula with the lateral collateral ligament on the lateral side, and between the femur and tibia, the medial collateral ligament. If I look inside the knee, when I flex it, I can see an anterior structure called as anterior cruciate ligament in the center, which is going mainly on the medial side. At the back, you have the posterior cruciate ligament and the meniscus, the cushions between the femur and tibia. Whenever there is a varus force in the knee, varus means distal part towards the midline. So in the varus force, it is the lateral collateral ligament which is damaged. In the valgus force, it is the medial collateral ligament which is damaged. And since our ACL also goes to the medial side, it is also damaged in the valgus force. When I look in between the knee, the meniscus or the cushions, they are damaged in the rotational force. And the cruciates also are damaged in the rotational force. So rotation with valgus is anterior cruciate ligament. The most posterior structure in the knee is the posterior cruciate ligament. It is damaged on the posterior force. So let's have a look. If there is a varus force, when there is a varus force, the lateral collateral ligament is damaged. When there is a valgus force, the medial collateral ligament is tested or damaged. When I flex the knee and I rotate externally, the structure which prevents external rotation of the knee, posterior cruciate ligament, the dial test. Remember the posterolateral area, which mainly has posterior cruciate ligament, external rotation, whereas the structure resisting internal rotation at the knee joint along with hyperextension is the anterior cruciate ligament, tested by the pivot shift test. For anterolateral corner, which has ACL, lateral collateral ligament, lateral half of the joint capsule. PCL restricts external rotation dial test. ACL hyperextension interrotation, pivot shift test. The most posterior structure on the upper end tibia, PCL, and ACL goes anterior and medial. So damage and rotation plus valgus force. The other test for ACL, you can keep the knee flexed to 90 degree, support the foot along with your body, exert the force anteriorly. If the tibia moves anterior in relation to femur, this is called as anterior draw test. When you do the similar thing in 20 degree knee flexion, it's called as the Latchman test. Remember the spelling Latchman. First three alphabets are ACL. That's why this is the best test for ACL. Some other tests for ACL, the Lely's test. So if I look at the different tests for ACL, you have the pivot shift test, you have the Latchman's test, you have the anterior draw test, and you have the Lely's test. So if I try to write down the mnemonic, P is pivot shift test for ACL. Apart from ACL, it will test the lateral collateral ligament and lateral half of the joint capsule. Then you have L, that is the Latchman test, the best test for ACL. Then you have NLE together, the Lely test. Then you have A and D, the anterior draw test. You know our ACL has got two elements. One, anteromedial fibers, and second, posterolateral fibers. Remember, the posterolateral fibers, they support the knee in extension. So in the mnemonic, first three alphabets tell you posterolateral fibers of ACL, they work in extension, whereas anteromedial in flexion. In the knee joint, in the athletes, sometimes three structures are damaged, and damage to these three structures has poor prognosis. These three structures are medial collateral ligament, anterior cruciate ligament, and medial meniscus. Remembered by the mnemonic, MAM is dangerous. This is called as unhappy triad of Donog's or O'Donoghue triad, poor prognosis in sports injury. O'Donoghue test is to differentiate between the damage to the cervical spine muscles or the ligaments, sprain versus strain. McMurray's is a rotational test used in case of the meniscus. Now, in meniscus, you have McMurray's test, you have the Aplay's grinding test, you have the Thesele test, or the Agace test, remembered by the mnemonic MEAT. And remember, the medial meniscus is damaged more than lateral because medial is fixed to the underlying capsule, lateral is flexible. Whatever is fixed and rigid, that's damage in the human body. That is what the attitude decides how you progress in life. The blood supply of the meniscus comes from outside in, so peripheral 1/3 is vascular, can be repaired. Inner 2/3, avascular, will not heal, so has to be excised. The medial meniscus, when it gets torn, it will buckle up at the posterior part of the knee, giving a double PCL sign, which tells you the bucket handle of the medial meniscus. In our knee, in our human body, in fact, we have different feels. Hard feel, two bones come in contact with each other. Firm feel, the overlying cartilage come in contact, or soft feel. So there are three consistencies of human body: hard, firm, and soft. When you try to extend your knee suddenly, if the femur and tibia rub against each other, it's a hard feel. This is a bounce home test, hard feel of a bone. If the cartilage rubs against each other, firm feel. And if there's a damage to the soft tissue inside, there will be a rubbery or a spongy feel. This is called as bounce home test of the knee joint. Empty feel is not seen. This question featured in AIIMS May 2013. And Kritika, who topped that exam, when she was discussing this question with a lot of people, people asked her, how did you crack this question? She said, I knew it was not a repeat. You know, a person who has prepared well will only come to know what's a repeat. If your preparation is not up to the mark, everything appears new to you. So, she was prepared well. She knew what were the topics in last 3 years, what was a repeat. But then, she told herself, let's try to get this question correct. So she's talking to herself during the exam. A trait which is very, very important for a student who's appearing in entrance and is giving a big exam. And then Kritika thought, in human body, you have a hard feel of a bone, firm feel of a cartilage, soft or rubbery feel. She looked at the option. Option were hard, firm, soft, empty. In bounce home test, which feel is not seen? And she marked the answer empty. Without even knowing, applying a common sense, she did that. She was asked this question, ma'am, how were you so calm to answer? She gave a very simple answer. I knew that it's not a repeat. And if I get this correct, it will take my rank up. So, keep thinking. Never give up. When you look at the relationship of tibial tuberosity to the level of the joint, remember, whenever the knee locks or unlocks, in locking phenomena means when you're standing, the locking means the femur rotates inside. The distance between the tibial tuberosity and the lateral side of the knee decreases. Or if you're sitting and when your knee flexes out, again the tibial tuberosity goes toward the lateral part of the knee because it external rotates. This is the Hefflet test. Whether you are in extension or in flexion, the tibial tuberosity will go toward the lateral side of the knee joint. Hefflet test. If your meniscus is torn, this rotation is hampered because meniscus is a cushion that allows the knee rotations. If you go from anterior to posterior in the knee, the first structure in the intercondylar area, which is right in the center, is the anterior horn of the medial meniscus. That is the first structure. Followed by anterior cruciate ligament, anterior horn of lateral meniscus, followed by posterior horn of lateral meniscus, posterior horn of medial meniscus, and posterior cruciate ligament. So Medical College Lucknow Medical College, structures from anterior to posterior in the intercondylar area, very, very commonly asked in the anatomy area, also in the applied anatomy of orthopedics. Most posterior structure on upper tibia, PCL. Most anterior horn, medial meniscus. Remember that.